perspectives from a multidisciplinary team. This slide shows the disclaimer. This information has been reviewed according to and is consistent with EU prescribing information. I would like first to start with a welcome and introduction. So my name is Jean-Yves Blay. I'm a medical oncologist working in Lyon, France, and together with me, a prestigious faculty, Dr. Brose from the University of Pennsylvania, USA, Dr. Garcia Foncilas from the Autonomous University of Madrid, Spain, Dr. Ockmeyer from Vienna North Hospital in Vienna, Austria, and Dr. Weiner from Hadassah Hebrew University Medical Center in Jerusalem, Israel. On the topic of today, after a first talk on precision medicine in the era of emerging biomarker, we will have 3 clinical perspectives on patients' cases with non-small cell lung cancer, pancreatic cancer, and with thyroid cancer, presented by the different faculty members. At the end of the presentation, we will have discussion and closing remarks. So my name is Jean-Yves Blay. I'm a medical oncologist working in the Cancer Center in Lyon, France. My work is dedicated to precision medicine in oncology and also in the development of new agents in this field. These are my disclosures. And I would like to start first with a topic on precision medicine in the era of emerging biomarker. This is a topic very much of importance because we have been seeing in the recent decades a growing role of precision medicine in oncology, moving from a situation where we have conventional medicine prescribed for the different cancer patient in a one-size-fits-all approach to a situation where biomarker, which provide diagnosis and guidance for the molecular alteration of the tumor, enable us to propose a treatment which is adapted to the molecular alteration present in the cancer cell and which is driving the tumor cell. In 2019, 25% of all FDA drug approvals were personalized medicine. 7 diagnostic tests were approved or given additional indication in 2019. And as we speak, next generation sequencing and computational tools have created a massive opportunity to enable progresses in the routine management of cancer patients. This is an area which has been very much moving in the past decades. We started actually something like 40 years ago by the discovery that estrogen receptors were being expressed on breast carcinoma and being correlated to response to hormonal treatment. And then we moved progressively to the identification of a sequence of biomarkers, HER2 amplification, BCR-ABL, mutation on epidermal growth factor receptor in non-small cell lung cancer, in ALK kinase, mutations also in KIT, and in a variety of different tyrosine kinases and beyond, moving more recently to a very rapidly growing number of molecular alteration, which enable us in the last 2 years the identification of new novel biomarkers and novel treatment for selected patients with advanced cancers. An example is given for gastrointestinal stromal tumor, which was one of the first solid tumors where the identification of a biomarker, a driver molecular alteration, was found associated with a massive improvement in both progression-free survival and overall survival. The KIT receptor tyrosine kinase is frequently mutated in these cancers. And if it is not KIT, it will be PDGF receptor alpha, which is a cousin tyrosine kinase receptor, which is being mutated, activated in these tumor types. These different mutations are present on a variety of different sites in the molecule, but they all confer to the kinase an activation stages, which is independent of the presence of the ligand. If we block this activated kinase with tyrosine kinase inhibitor, we are able to improve very significantly the progression-free survival and the overall survival of patients with advanced disease. And as we speak, more than 20 years after the first introduction of this treatment for the routine treatment of patients with a gastrointestinal stromal tumor in advanced phase, we can see that close to 15% of the patients are still alive, progression-free after more than 15 years of treatment. And this is probably improving as we speak, as the treatment is becoming introduced more early for this patient population. The same is true for ALK translocated non-small cell lung cancer. Non-small cell lung cancer are affected with a variety of different molecular alterations, which makes it a very complex group of disease with a wide variety of different molecular alterations. So translocation involving the ALK protein result in the activation of this oncogene, which is one of the key drivers of a subset of non-small cell lung cancer. Using ALK inhibitors to block tyrosine kinase activity of this receptor enabled a significant improvement of progression-free and overall survival. And now we are speaking of third generation of tyrosine kinase inhibitor in the form of alectinib for the management of these patients. The most recent survival curves being shown on this slide, showing a significant, very significant improvement of the progression-free survival with the third generation of inhibitors. Here and today, we are going to speak of a new class of molecular alteration, which is present in a wide variety of different cancers. The NTRK gene fusions are indeed found in cancers of pediatric ages, but also in adults, in a wide variety of different situations. More than 25 different tumor types may be affected with such driver mutation involving a fusion gene with one of the NTRK genes. And sometimes these molecular alterations are very frequent in rare histological subtypes, such as secretory carcinoma of the salivary gland. Sometimes they are extremely rare, such as in colorectal cancer, in melanoma, and a variety of different sarcoma. In children, they tend to occur in a selected histological subtypes of tumors, such as infantile fibrosarcoma, and in some gliomas. These molecular alterations are altogether rare, but they can be present and be observed in a wide variety of different histological subtypes of these different cancers, again, both in adult and pediatric ages. In the last couple of years, we have observed a growing number of TRK inhibitors being developed for this treatment of these entities. Larotractinib and Tractinib, more recently Larotractinib and Larotractinib, are first and second generation of inhibitors, which, as we can see on this slide, are able to inhibit TRK ABC, but also for some of them, ROS1 and ALK, and for some of them also resistance mutation, which are started to be identified as a mechanism of resistance for the first generation of TRK inhibitors. So this is a very active and lively research field that is being further investigated in clinical trials, as we are going to see in a few minutes. One of the inhibitors of the first generation is Untitled, which was tested in patients with TRK fusion cancers, as we can see, because it's a rare population of patients, in a variety of different clinical trials involving a variety of different tumor types with different alteration. We can see TRK fusion cancer, we can see ROS1 positive non-small cell lung cancer, and a pediatric analysis set. Here we are going to speak of the TRK fusion cancer group, study the safety population being a population of 113 different patients. And without getting too much into the detail, we can say first that we have a population of patients which are evaluable for volumetric response, and a population of patients which is characterized by the absence of measurable disease. But let's have a look first on the overall response rate of this agent, Entrectinib. As we can see here, the response rate, complete response, and partial response rate are very impressive, with very few actually progressive disease being observed as best clinical response. What is extremely important is the observation of response and tumor control in all histological subtypes of the tumor, defining what we are going to discuss today, which is the histoagnostic characteristics of this treatment. This slide shows you in the same patient population the overall survival, progression-free survival, and duration of response, which was observed in this patient population. Here, the efficacy population of 74 patients. Median overall survival, close to 24 months. Median progression-free survival, close to 11 months. Median duration of response, close to 12 months. Of course, side effects were observed in this patient population. Close to 9% serious adverse events were reported in the safety population of more than 300 patients, with dose interruption in a quarter of the patient and dose reduction in about the same proportion. 4% of the patient had to discontinue the drug because of these adverse reactions. The other drug, which is one of the first generation of agents able to block NTRK inhibitors, is Larotractinib. It has been, again, investigated in a variety of different patient clinical trial, from phase 1 to pediatric phase 1 to adolescent phase 2, which are gathered on this slide. First, you have a primary set of patients which were gathered in the first publication, complemented subsequently by a supplementary set, putting together a large series of 159 patients with TRK fusion cancers. These patients were gathered in these different clinical trials with the aim of identifying primary endpoint, which was the objective response, assessed by local investigators, and secondary endpoint, again, duration of response, progression-free survival, and overall survival, and of course, safety. This slide shows you baseline characteristics of patients treated in these different clinical trials with Larotractinib. We can see that the gender is balanced. The majority of patients had good performance status. As you can see also on this slide, a majority of patients has received at least one or more lines of previous treatment. A significant proportion of patients had brain lesions associated as secondary tumors, a bit less than 10% of the patient. And we can see on the right-hand panel that the majority of tumor types were represented by sarcoma, but also thyroid, salivary gland, lung, colorectal carcinoma, and also a wide variety of different histological subtypes. There are 3 NTRK genes, NTRK1, 2, and 3. The majority of mutations were observed in NTRK3 and NTRK1, but basically all the 3 genes were one of these fusion proteins. Let's say that these different fusion genes and proteins were, of course, mutually exclusive. This slide shows you the very impressive waterfall plot observed in this data set. Again, you can see something which is extremely important is that tumor control was observed in all histological subtypes. A large proportion of patients were in complete response in this data set. The majority of patients actually were in partial or incomplete response. This raised up to 92% of the pediatric patient population, 73% of the adult population. Only very few patients were in progressive disease as best response. This slide shows you the duration of response to Larotractinib. We can see here an impressive median duration of 35.2 months for this patient population, so long-lasting response being observed in those patients with confirmed response, 108 patients. We can see also the progression-free survival and the overall survival. Again, an impressive 28.3 months of median progression-free survival and a median overall survival of 44.4 months. Again, something which is very impressive for this patient population, which for most of them had no alternative options for the treatment after having failed the previous classical treatments. What about the safety? Again, the safety was quite favorable. Only a minority of patients were experiencing grade 3 or grade 4 toxicity, regardless of the attribution. And regarding treatment-related adverse events, we can see that the proportion was also very limited. This is a treatment which is overall very well tolerated. And we can see on this slide that actually the safety population and the TRK fusion cancer population had very few dose reductions and very few treatment discontinuation related to treatment-related adverse events in less than 2% of the patient, mostly. All right, so we have seen the impressive results of the first generation of NTRK inhibitors, which are long-lasting for the majority of patients, but we know that resistance may emerge, and we have been observing the interesting preliminary result of second generation of TRK inhibitors, which are able to address TRK resistance mutations, which are sometimes being observed on some of these patients. This was the case for Larotractinib, which blocks TRK A, B, and C, and which reported impressive, again, response rate of 45% in the phase 1/2 clinical trial. This is also the case for Larotractinib, which is an agent which was more recently introduced into clinical trial and for which the clinical information is more immature as we speak today. So how do we identify these patients? We have a variety of different methodologies to enable the identification of this mutation. And the first one is next generation sequencing, NGS, which enable us to test DNA or RNA in the tumor cells and enable to identify the exact partner of the fusion gene and, of course, of the fusion protein in each individual tumor type. But these are, of course, rare mutations, and therefore we may need to submit a large number of samples to this genetic test, which may be not accessible everywhere. So other strategies have been to use the indirect immunohistochemistry tool to identify the expression of the TRAC, of one of the TRAC protein, and to enrich into a population of patients on which NGS could be applied. We also have direct identification of the translocation, which may use in situ hybridization when we know that a specific fusion protein and fusion gene is observed in a given histological subtypes. And more classically, we may use also reverse transcriptase polymerase chain reaction when we know what is going to be the partner of the fusion gene. So we have a wide variety of different methodologies for NTRK testing, from screening using immunohistochemistry down to the refinement of next generation sequencing, which is currently being more and more used for the identification of these patients. And this is, of course, very important, but because we have seen the results achieved with the first generation of inhibitors, it is important to be able to identify this mutation in order to propose this treatment to these patients when they lack alternative options, of course. So in summary, we have been seeing in the last decades major advances in precision medicine, which led to the development of treatment adapted to the molecular alteration observed in the cancer cells. Driver molecular alterations have been identified in a wide variety of different histotypes. Testing for NTRK fusion is now essential to identify patients who may benefit from these TRK inhibitors. We had a variety of tests to enable the identification of these fusion proteins and these fusion genes. And this is going to be the future on how we integrate these diagnostic tools to the armamentarium of diagnostic tools that we have at our disposition for precision medicine in order to enable our cancer patients in advanced phase to benefit from this new generation of inhibitors, which provide such impressive response rate and long-term duration of tumor control in this patient population. Thank you very much for your attention. And with this, I would like to introduce our next speaker. Our next